time, rather than going straight to the amino acid formula, which tends to be expensive, you have to try the hydrolyzed product first. Now, this is a time-consuming process, and meanwhile, you've got a baby in distress and quite possibly a family under stress as well. Can you understand why a doctor or a dietitian might reach immediately for the amino acid formula at the top of the ladder?
Absolutely, but I think we've got to look at the baby perhaps, and in an otherwise well baby with growing beautifully, who has a few issues but weight is still increasing steadily, then I think it's worth going through the other steps. If we've got a baby whose growth is severely compromised, maybe with severe eczema, then maybe we need to go to the top and work backwards. Typically you'll notice within hours or minutes if the baby's going to have an issue with an extensively hydrolyzed formula.
So by and large, this process of trialling is not going to be something that is going to go painfully on for weeks and months. That's not going to be the normal situation.
Not with an IgE-mediated cow's milk allergy. It might take a lot longer with, as Jan was mentioning, some of the other presentations, and sometimes we do need to look at weeks for those sort of presentations.
Let's come back to those other presentations, because I'm sorry, it's describing a large proportion of the children I see. Yeah, they've got a bit of eczema, they've got a bit of colic, the parents are struggling, perhaps because there's no grandparents around. So how do I try and differentiate those who may have cow's milk allergy to what I sometimes call as snotty children?
It's possibly easier if the baby's still exclusively breastfed, because then we can just withdraw milk from the mother's diet, and does it improve? Does it deteriorate again when we add the milk products back in mum's diet?
And if it does, if the child does deteriorate, then you try the hydrolyzed formula?
We'd still encourage breastfeeding as being the first option, and then depending on the child, we need to moderate the amount of milk in the mother's diet. I'd typically start with just avoiding major sources of dairy. So the little bit, butter shouldn't be an issue at all, and little bits of milk solids in a cake or a muffin, probably not an issue, but a glass of milk, carton of yoghurt, piece of cheese is probably going to be too much.
I suppose, from a GP's point of view, when do you want to see them, Jan?
Well, I think the IgE-mediated allergy is reasonably straightforward, because many of those children will end up being seen by a paediatrician for assessment and for management of the whole area of allergy. Can they be managed in primary care? A lot of them probably can. I think it's about having enough time to really assess the problem. If you take 100 kids with IgE-mediated cow's milk allergy, probably 40 of them are egg allergic, maybe a similar number potentially peanut allergic. They need dietary advice. They need to know what to do with accidental exposures.
Peter, you've made it very clear that there is an economic cost to going straight to the amino acid formula as a first line.
Surely.
That cost is blowing out. But do you accept that there may be a psychological or a mental cost to hanging around and trialling stuff before you actually reach for the amino acid formula?
Yeah, I mean, I think this is a very important issue.
Is there any flexibility in the regime?
Well, the rules at the moment are the rules, and we'll need to look at that as time goes by. But I think there's two things. One is that that in general practice in primary care, you're often seeing the much greyer areas here. And you made the comment there that that you could tell whether, in fact, hydrolyzed formula was going to work within a few hours. I wonder whether that's really the case when you use it in primary care, with these earlier presentations perhaps not quite so severe.
Well, no, I think you're right, so that you can tell if it's not going to be tolerated with the IgE-mediated conditions, because you tend to get reaction. You can't tell if it's going to help some of the non-IgE-mediated conditions immediately. That's going to take a longer period.
Sure.
Yeah.
Yeah.
One of the questions is, parents will often ask, will they grow out of it?
Yeah, and if you're looking at non-IgE mediated stuff, that tends to go away much more quickly, so probably 85% by the age of 2. Yeah. So tolerance to cow's milk improves very rapidly in those kids. The kids who've got IgE mediated cow's milk allergy do generally grow out of it, but it's actually a much slower process than we used to think. So that old textbooks say 85% by the age of 3. Some of the studies now would say maybe 85% by the age of 8. So much slower than we thought.
We've got an audience here with us at Avalon in the studio, and I know that some of them are here to ask questions. And I'm looking now. Can I ask whether there are any questions that you want the panel to address themselves to? Show of hands? Yes, over here.
I'm interested in your advice to a parent who's concerned about the use of, say, a soy infant formula and the risk of an allergy there, the children over 6 months of age.
So I think, again, if you look at old textbooks, they say soy milk and cow milk cross-react and maybe 25 or 30%, which is not true. Soy milk and cow's milk don't cross-react. They're very different proteins. If you've got cow's milk allergy, you're at increased risk of having other food allergies, and that might include soy. So if you're not soy allergic, soy's a good alternative.
Do we know whether the use of soy formula prevents the development of allergies later on?
Yeah, we do. I know it's not preventative, but it's a useful alternative if you are cow's milk allergic and can't have dairy.
We've got a text question, I think, as well, which is this. It's from Tonya, who's from Queenstown, who asks, what's the recommendation for babies with clear cow's milk intolerance or allergy, e.g. very severe nappy rash, which responds to dairy exclusion, but the child will not take Pepti Junior as formula? Who wants to answer that?
Depending on the age of the child, we could use soy instead. I mean, we'd have to ask why we're going to Pepti. And we often find with these hydrolyzed formulas, they do have quite a distinctive taste, and often we'll doctor those for the first little while until we get the baby hooked. And things like adding pureed pear, some brown sugar, some vanilla essence, just to flavour it up a little until the baby is well established on it, and then we'd aim to get that out.
So Anna, is that information, say, readily available to the general practice team, or is it best to refer to a dietitian who can help the family? It's a bit like practice tips, isn't it?
Yeah. That sort of information tends to come with a lot of the manufacturers' information. So if a child is commenced on Pepti Junior, they typically get a little bit of information in a starter pack, and that has the information in it. I think where GPs need to consider referring on is where it's more than just a simple cow's milk protein allergy, where there are multiple allergies and where we're starting to take major nutrients out of the diet, or when growth is faltering.
I mean, there is another issue, and that is where we actually believe it's not related to cow's milk allergy, but it's a number of factors around parenting skills, social networks. Sometimes we refer just so there's another person who will confirm that it's not an allergic problem. Is that an appropriate referral, Jan?
Absolutely. Yeah.
Everybody's been stressing the fact that breast is best. I've got a question there. I mean, if the baby is breastfeeding, it may be a matter of putting mum on a dairy-free diet, presumably with extra calcium. In practice, I wonder how much of a stretch that's going to be. And the situation I'm looking at is the possibility, well, the virtual certainty, that the mum is going to be alcohol-free during the pregnancy and then dairy-free for the first 6 months at least after the baby is born. How much of a stretch is that?
Well, she'd be able to drink alcohol again, so... Sorry.
I think in withdrawing the dairy from the mum's diet, we need to get it out first, get the baby improved, and then start adding it back into her diet and see where our threshold is. The threshold of how much milk the mother can consume with a milk allergic child will vary between every mother-baby combination. And so there's no one formula for every combination.
So Anna, would you normally exclude all dairy and then add a wee bit more in? And what is exclusion of all dairy?
I typically exclude major sources of dairy. Cartons of yoghurt, drinks of milk, pieces of cheese, probably even milk in the tea or coffee, but leave it in baking. And I'd really encourage mum to use soy as an alternative. Then she can go out and have a soy latte. She can still have some soy yoghurt.
And when would you normally expect to see a response in the child on that regime?
Probably over a couple of weeks, although some babies I see improve within 2 or 3 days. It does take, it won't be an overnight, it takes 2 or 3 days for the milk protein to work through the breast milk.
And when that child is starting to wean, should they avoid milk products as well?
I tend to look at what else is going on in the child at that time, and I would tend to go to a soy formula. If the child's had that issue through breastfeeding, I would tend to take the cautious route with a soy formula initially, because many children are introduced to soy at maybe around about that 6-month age. And maybe by the time they're 8 or 9 months, then we could try a little bit of cow's milk, not as the major formula, but just mixed into their food, or a little bit of yoghurt, and see how they go with that.
Jan, there's no doubt that there's been an increase in the use of formulas. Is that because kids these days, more kids are showing up with indications of cow's milk allergy than used to be the case? And if that is the case, why is it?
We think it is the case. So certainly through the Western world, the States, the UK, Australia, New Zealand, there does seem to have been a marked increase in the number of kids presenting with typical food allergy, not only to cow's milk, also egg, peanut, other common foods. And I think it's fair to say we don't really know why that is. There's a whole lot of theories and nothing's really proven at the moment. I guess some of the, without knowing what's caused it, people are trying all sorts of things to see if you can reverse the trend. And part of that relates to the idea of how you get kids tolerant of foods as opposed to allergic to foods. Some of the studies are actually introducing things earlier rather than later to see whether that makes a difference and reduces the rate.
In terms of the regime that we adopt to deal with it, I saw some statistics that really surprised me, that our use of amino acid formulas in New Zealand is 60% higher than Australia's on a per capita basis. Right. And that in this country, 78% of infants are using the amino acid formula without the trialling of the hydrolyzed stuff first. Although the literature suggests that only about 10% of infants need it.
I think the Australians have had recommendations for the hydrolyzed for a while before we have. So I think we're sort of going down that road. Do you agree with that?
Yeah, I mean, I think the other big difference is that we have one extensively hydrolyzed formula on the market, which is nowhere near as extensively hydrolyzed as some of the alternatives that are available in other countries, which means that when we look at the kids with cow's milk allergy, IgE-mediated allergy, in fact, half of our kids fail the formula that we do have available. They still react to it. It's got some big bits of protein that are too big. So it's partly to do with what we've got in the marketplace. We've only got one extensively hydrolysed available, so our rate is going to be higher than countries where there are alternatives.
Can I ask one question? That as we widen access, this stuff is going to be used more. And are there any risks, are there any disadvantages in using, whether it's soy, whether it's hydrolyzed, whether it's amino acid formula?
Well, potentially. I mean, we still don't really know why some kids get allergic, and there's data suggesting, say, that later introduction of peanut may actually increase peanut allergy, and that later introduction of wheat may increase wheat allergy. Yeah. You know, we don't want to
create that situation.
Exactly. Yeah.
Peter, you're widening the pool of who can prescribe, not just specialists have access now, but GPs and dietitians too. It seems counterintuitive to me that you'd widen the prescriber pool and expect less prescribing as a result.
I don't think we expect less prescribing. I don't think that was ever our intention. It was trying to rationalise it. So firstly, because the number of highly specialised immunologists that are around is pretty sparse. I don't know how many. There's about 3 people in the country who have got your qualifications, and these people with these problems are not going to be able to get to that level of specialisation. So yes, we're trying to widen that access, and we fully accept that we may actually be increasing access.
Thank you to Dr. Jan Sinclair and Anna Richards, who are leaving us at this point.